My name is Dr. John Malcolm, and I am one of the robotic surgeons at Urology of Virginia. In this video, I will introduce robotic partial nephrectomy and robotic total nephrectomy, which are the surgeries used to treat kidney cancer. Kidneys are the organs that filter the blood, and they are critical for life. The main parts of the kidney are the kidney artery that carries blood into the kidney, the working part of the kidney where the blood is filtered, the ureter that carries the waste products or urine out of the kidney, and the kidney vein that carries the filtered blood back to the body. Cancerous tumors can develop in the filtering part of the kidneys, and these tumors are most often treated with surgical removal. Small kidney tumors are usually identified accidentally when patients get CT scans or other X-rays for unrelated reasons. Small kidney tumors usually do not cause any symptoms. Large kidney tumors may cause symptoms such as bloody urine or pain in the flank area. Your urologist may recommend a biopsy to prove that a tumor is cancerous prior to surgical treatment. Or in some cases, particularly for large tumors, a biopsy may not be recommended because the radiographic appearance of the tumor is concerning enough to recommend surgery without a biopsy. There are two types of robotic surgery for kidney tumor removal. Partial nephrectomy, where only the tumor and a small rim of healthy kidney tissue is removed while the rest of the kidney is preserved. And total nephrectomy, where the entire kidney is removed. Generally speaking, total nephrectomy is a simpler surgery, and partial nephrectomy is a more complex surgery with a slightly higher risk of short-term complications. Despite the risk of short-term complications, it is often preferable to treat kidney tumors with partial nephrectomy so that optimum kidney function can be maintained for the long term. The decision to perform total nephrectomy or partial nephrectomy depends on the size of the tumor, the location of the tumor, and the functional status of the opposite kidney. A normal kidney is about 12 centimeters in size. Tumors greater than 7 centimeters in size, or more than half the size of the entire kidney, are generally considered large and typically will require removal of the entire kidney for treatment. Tumors are considered small if they are less than 4 centimeters, and they can most often be treated with partial nephrectomy. Tumors between 4 and 7 centimeters might require either partial or total nephrectomy. Tumors in the top or bottom of the kidney are further away from the main blood vessels, so even larger tumors can often be treated with partial nephrectomy. Tumors in the center of the kidney are surrounded by large blood vessels, so even small tumors in the center of the kidney may sometimes require a total nephrectomy. If the opposite kidney works perfectly, there may be less reason to perform the more complex partial nephrectomy, and total nephrectomy may be a better choice because one good kidney is all that is needed for a long life. If the other kidney has diminished function, even complex or large tumors may be best managed with partial nephrectomy so that the overall good kidney function can be preserved. Your urologic surgeon will review your CT or MRI scans with you and help you decide which treatment, partial or total nephrectomy, is most appropriate for your situation. Factors that are unrelated to the tumor itself, such as your overall health status and physical tolerance for post-operative complications, will also have to be considered. Risks and benefits of different treatment options have to be weighed in an individualized manner so that you get the treatment that is best for you. When robotic partial nephrectomy is selected for treatment of your tumor, you should prepare for your surgery according to the standardized Urology of Virginia ERAS pathway, which is described in a separate video. During the surgery, robotic instrumentation and robotic visualization will be established, as shown in a separate video. Then surrounding structures will be carefully moved to the side and the kidney will be identified. The blood vessels that feed the kidney will be isolated. The tumor in the kidney will then be located and the edges of the tumor will be identified and marked using a combination of visual inspection and ultrasound mapping. Clamps will be placed on the kidney artery to temporarily stop blood flow to the kidney. Then the tumor will be removed from the kidney and placed in a specimen bag. The opening in the kidney will then be repaired with sutures. And the artery clamp will be removed to restore blood flow to the kidney. Visual inspection will confirm that the kidney is in good working order, with no bleeding outside the kidney. Finally, the specimen bag will be removed and all the robotic incisions will be closed. In some cases, your surgeon may leave a drainage tube next to the kidney to help monitor for urinary leakage or bleeding. At the conclusion of the surgery, the tumor is removed from the specimen bag and sent to a pathologist who will assess the tumor characteristics and provide a detailed report. The specimen edges, or margins, will be evaluated to confirm that the tumor removal was complete. A negative margin means that the tumor was completely removed and is unlikely to return. A total nephrectomy follows a similar set of steps as partial nephrectomy, but instead of clamping the blood vessels and removing just the tumor area, the vessels are divided with a stapling device, and then the entire kidney is removed and placed in a specimen bag for removal. There are 3 important risks with partial nephrectomy that do not apply to total nephrectomy. First, a positive margin. A positive margin means that there are cancer cells on the edge of the specimen that was removed from the kidney. This means there is a small chance that the tumor could grow back in the kidney. This requires close monitoring with periodic CT scans or MRI. A positive margin with robotic partial nephrectomy is a very, very rare occurrence, around 1%. Second, a pseudoaneurysm. After a robotic partial nephrectomy, the blood vessels in the kidney may develop a small leak that results in blood flowing into the urine within the kidney. The sign of this complication will be bright red urine or urine with large blood clots. If these signs occur, you should return to the hospital where your surgery was performed, and radiology tests can identify and correct the pseudoaneurysm. Pseudoaneurysm is an uncommon complication, less than 5%, but it is the most serious of the 3 outlined here, and it requires prompt attention if it occurs. Third, a urine leak. When tumors are removed from deep within the kidney, some of the urinary tubes inside the kidney may be cut away in order to allow complete removal of the tumor. The urinary tubes are then closed with suture, but in rare cases, the closure may develop a leak, and urine may collect outside the kidney. A drain is sometimes placed during the surgery if the potential for a urine leak is felt to be high. The drain will be removed when it is clear that the kidney is healing properly, usually after 1 to 2 days. If a urine leak is identified and there is no drain in place, a radiologist will place a drain which is left in place until the kidney fully heals and the leak resolves. A urine leak after robotic partial nephrectomy is uncommon, less than 5% of cases. Signs of a urine leak include fever and worsening pain in the kidney area, often more than a few days after surgery. Other surgical risks that are common to both partial nephrectomy and total nephrectomy include inadvertent injury to surrounding structures, bleeding, heart attack, stroke, blood clots, and pulmonary complications such as pneumonia. Input from your primary care physician may be required to help determine your fitness for surgery. A comprehensive discussion of kidney function after partial nephrectomy and total nephrectomy is beyond the scope of this video, but in general, partial nephrectomy leads to better preservation of kidney function overall compared to total nephrectomy. Total nephrectomy is associated with higher rates of chronic kidney disease and associated health problems, particularly for patients with diabetes and/or pre-existing chronic kidney disease. After your robotic partial nephrectomy surgery, you will be admitted for an overnight stay. You will have a bladder catheter overnight to help monitor urine output and appearance. The catheter will be removed in the morning after surgery. Labs will be drawn to confirm good kidney function and no bleeding from the kidney. Then you will be discharged to home with prescriptions for pain medication and a stool softener. The Urology of Virginia ERAS pathway is used for both robotic partial nephrectomy and robotic total nephrectomy. Please refer to the ERAS video for additional information. After robotic partial nephrectomy and after robotic total nephrectomy, you should avoid lifting anything over 10 pounds and all strenuous physical activity for 1 month. I hope that this video has been informative. Please refer to the link below for written supplemental information. Thank you for choosing Urology of Virginia for your robotic surgery needs.